Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Noha Balata from Roots Community Health Center, reporting for the week of July 11th, 2022. After a brief pandemic status update, I'll be talking about the BA.5 and also about what we know about Paxlovid Rebound and what to do about boosters. As health professionals rooted in Oakland, serving some of the people most vulnerable to getting and suffering from COVID-19, we're here to cut through the noise to give you information you can use to make choices that will keep you, your loved ones, and your community as safe as possible. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. Please submit your questions in the comments by direct message or by email to admin@rootsclinic.org. Here we can see Alameda County total daily cases. This graph is lagging behind a little bit. The most recent day shown here is July 6th, and the last 7 days are shown in black. Those we know will continue to be updated over the coming days, so really difficult to say whether we're plateaued or which direction we're going here. Likewise, this graph is also a little bit dated. This is a 14-day average that is showing to be coming down, but this is as of July 4th, so running about a week behind here. So we'll just continue to keep an eye on that. Unfortunately, our positivity rate just continues to climb. It's over 14% now. And so we know that the last 3 slides that I've shown are based on lab confirmed tests. So we know that that's just a fraction of the overall tests that are being done. Nonetheless, that's what we have to go on. So we're going to continue to look at the direction these things are going and make note of that. What's important to look at here is our hospitalization numbers, and those are just kind of, they're going a little up and down, but really in general still heading up. So this is really concerning. We hate to see this. When I reported 2 weeks ago, we were at 136 in the hospital and 17 of those in the ICU. Unfortunately, now we are at 148 in the hospital and 20 of those in the ICU. So it's of course concerning for anyone to get sick enough to be admitted into the hospital with SARS-CoV-2. So this is certainly heading in a bad direction still. With regards to vaccination, Alameda County has done really well. We have over 86% of our county that is fully vaccinated, and that's compared to 78.4% in the United States. We're still lagging behind in certain groups. And so in terms of age, with our 5 to 11-year-olds, we're at about 63%. So we'd of course like to see that come up. And in terms of the racial, ethnic demographics around vaccination, we're still seeing African American and Latino residents of Alameda County at 70 and 71% fully vaccinated, respectively. So that's a whole 15 percentage points below the average. So we still got a lot of work to do there. When we look at the wastewater, this is lagging behind just about 2 weeks, but it's still just kind of heading straight up. So that's, not good news. We haven't exactly figured out how to really use this as the early warning system that we thought it was going to be. But we're still keeping an eye on it just to try to understand as many different sources of data as possible, and hope to be able to see this going in a different direction soon. But as you can see here, still continuing to go straight up. When we look at our variants, you can see that BA.5 there in the dark green is just absolutely taking off and taking over. We know that it's quite a bit more contagious or transmissible compared to the ones that it's outcompeting now, the other Omicron subvariants. BA.2.12.1 is the main one that we were concerned with before. BA.5 is just kind of displacing everything so far. And it also does a better job of evading our immunity that we might have had from prior infection or even from vaccine. But it still does appear that our vaccines are holding up fairly decently. Is BA.5 more virulent or cause worse illness? We don't really know that yet, and so we're going to have to keep an eye on that. But one thing that is of note, and really not sure why this is that normally we've seen the variants sort of take hold on the East Coast first and then make their way on over to the West Coast. And for some reason, we're just not seeing quite as big of a proportion of BA.5 on the East Coast and in the Northeast as compared to sort of the South and the West Coast. So not sure what that has to do with exactly, but I'm sure we'll be learning more as far as the spread of this variant goes, how it's doing competing against other variants, and what all the different factors that are at play. But I think the bottom line is that we do have a variant here in BA.5 that is getting through our prior immunity more successfully than the variants before it. And that is why many of us are starting to see folks around us who maybe have avoided it up until now are now catching it. And also, I think even more concerning perhaps is that people who have gotten it already, even recently, even within the last month or two, are getting reinfected now. So this reinfection is happening a little bit quickly, and that seems to be because even a recent Omicron infection doesn't seem to be protecting against the BA.5 variant. But still, as I've said before, getting exposed is inevitable, but getting infected is not inevitable. So if we're continuing to be vigilant, mask, up to date on vaccines and boosters, which I'll talk about a little more in a minute. Also, when someone close to us does catch it, don't just assume you're going to get it. Just because you live in the household with someone who has it doesn't mean you're necessarily going to get it. And I did talk in detail about how to avoid household transmission in a prior briefing, so you may want to check that out. And of course, if you catch it, then we're going to want to see if you're eligible for treatment and get treated right away, if so. So wanted to talk a little bit about treatment. And so as a reminder, we've got 4 approved outpatient treatments for SARS-CoV-2. And our first line, kind of our first choice, is going to be Paxlovid in the vast majority of cases. So this is approved for 12 and up. It's really for folks who are at risk of progressing to severe outcomes. And the CDC has a list. It's quite an exhaustive list. The link is in the post of conditions that would put one in this category. And really, it's ending up meaning that the vast majority of people are actually in this category. And so I think this creates a little bit of maybe gray area or confusion, but I'm going to get into it in just a moment. The next 2 treatments, remdesivir and the monoclonals, are IV treatments. There are certain situations where those are warranted. And then the final kind of last line is molnupiravir, not as effective, but it is oral. And so if you, for some reason, cannot give Paxlovid and you need oral, then that's where the molnupiravir might come in. And in all of these, we really want to start it as soon as possible after diagnosis. And it's really not related to symptoms. And so although there seems to be a little bit of debate out there, I think in general, we can agree that like most antiviral treatments, the sooner we start them, the better. I think part of the question is coming up of, is the treatment long enough, and when should we really start it? And the reason why those questions are starting to come up seems to have to do with this rebound phenomenon that's happening, that's causing folks to start asking these questions. So I'm just going to take a moment to kind of review a little bit. So we'll remember that Paxlovid, the initial trials, were just, phenomenal, showing 89% reduction in progression to severe COVID. So it was reducing hospitalization and death so significantly compared with placebo, and there really weren't any safety concerns, in people who were eligible to take the treatment. And it's a 5-day oral treatment. So really a huge breakthrough in how we were approaching SARS-CoV-2 infection. And so following that initial trial, the medication was approved under emergency use authorization. That was in December of 2021, kind of right as we were getting into the Omicron wave. And unfortunately, production and distribution and so on did not really ramp up in time to catch that Omicron wave. And so unfortunately, we lost a lot of people during the Omicron wave that may have been potentially saved by this treatment, which is a life-saving treatment in those who are at risk. Now, the study itself really was looking at unvaccinated individuals and folks with, who were at risk of progressing to severe illness. And what it showed in the study was about a 1 or 2% of rebound, so symptoms coming back after the 5-day treatment. So that was the original study that led to the drug authorization. Now we've got some time under our belt with Paxlovid, and so we've got some real world data. More and more is coming in all the time. There's a lot just in this last week or two. So I'll just highlight a couple briefly. So there was a study that looked at the real world effectiveness of both Paxlovid and molnupiravir, so the two different oral treatments for inpatients in Hong Kong during the Omicron waves. This is important because it was during Omicron. And they looked at, and they were doing more molnupiravir. So they had 1,000 people that got Paxlovid, 2,300 that got molnupiravir. This was actually, it's still a preprint from May. And basically what it showed was that mortality from all causes, also whether the person needed a ventilation, mechanical ventilation or not, or whether they needed to go to the ICU, was all reduced with these oral treatments. And they also showed that the viral load was also suppressed considerably with these medications. So this is kind of what's expected, but it's just sort of confirming it in a real world observational study. There was also a study printed in June, this past June, and this one was from Israel. And this also looked at the Omicron time period and showed that Paxlovid is highly effective in reducing the risk of severe COVID-19 or death from COVID-19. And so, and one of the things that they concluded was that the Paxlovid is more effective in older patients, immunosuppressed patients, and patients with underlying conditions like neurological or cardiovascular disease. And so, and they did not find a big difference between the Paxlovid treatment as it related to the vaccination status. So this sort of suggests that we want to be focusing on people who are at risk, whether they're vaccinated or not. And so we know that not being vaccinated is a risk factor for progression, but also being of older age and also having underlying conditions. Basically, those are the folks that we should want to treat with Paxlovid. So still kind of in line with what I think the original study suggests and what the guidelines are. But the guidelines, of course, are much broader than that. So this is where I think it starts to lead to some of those gray areas that I'll talk about a little more in a sec. I wanted to first point out this MMWR, the Morbidity and Mortality Weekly Report that came out just June 24th. And it was looking at data from Kaiser, Southern California, and they were looking at hospitalization and emergency department use. And they were looking at 5 to 15 days after Paxlovid prescription in over 5,000 individuals. And once again, I think just sort of showing that Paxlovid was preventing hospitalization. And this one, what was interesting was showing that even with people with mild to moderate cases of COVID, were prevented from going to the hospital. And this was in the higher risk population. So I think, again, hearing the same thing again, if someone is at risk of progressing to severe disease, they should get Paxlovid. We're not waiting to see if it's a severe case of COVID, because by that point, it actually might be too late to give the outpatient treatment. So even in people, so from this Kaiser study, even in people with mild to moderate cases of COVID, they're at risk for progression to severe disease. Giving them Paxlovid is still looking like it's a good idea. So saying all of that to say, not only did the original study show some very, very compelling results with Paxlovid, but also our real world data all seems to be confirming that if you are older, if you have underlying conditions, and if you are not vaccinated, those are all reasons why you'd want Paxlovid. And it's worth noting that none of those things do you need to wait to get COVID before you determine whether you should be getting Paxlovid or not. So I know I've said this over and over, but you should decide this now. Are you going to take Paxlovid if you get SARS-CoV-2 or not? And unless you're one of those people in the gray area, which I'm going to talk about, then you should already have had this conversation with your doctor, know how you're going to get it, and just know that if you test positive, you are going to start your course of Paxlovid. And based on what we know, and the study really looked at starting it within 3 days. So we already gave some leeway by saying within 5 days. So pushing it out further than that, there's just no evidence at this time that that is a good idea. Lots of speculation out there, but just no evidence at this time that we should do anything different than start it as soon as possible after you turn positive. So what about this Paxlevid Rebound? How concerned should we be, and what do we need to do about it? So there have also been quite a number of studies, both in preprint as well as published just within the last month about this Paxlovid Rebound phenomenon. And the original study that got the approval for the drug showed a very small amount, 1 or 2%, but it seems like, at least anecdotally, we're hearing about it a lot more than that. And mind you, we've given a lot of prescriptions. So I think this is what happens when you have real world data. You start to just learn more, and that is the state that we are in. But what is this Paxlovid Rebound? Well, it is basically that after the 5 days of treatment are complete, the person tests negative. They typically have either no more symptoms or much less symptoms. They finish the medication, and then within some period of time, and this is the part I think we're going to be still learning, but within some period of time, the person then has either a recurrence of their symptoms or a recurrence of a positive test, or both. And so this is something that we heard. It was very public when this happened to Dr. Fauci. And we know that Dr. Fauci actually received a second course of medication. This is not something that we actually have data about. This is not something that is currently recommended. And actually, this is something that's probably not really allowed for the most of us because this medication is under emergency use authorization, which means that doctors are not really to use this medication off-label like we're allowed to with things that are fully licensed. So we're going to want to stick with that 5 days. But what does it mean? And is that the right approach? And were there reasons to think that that was the right approach? So first off, I wanted to point out that there have been a couple of recent studies, a couple of them actually in the Clinical Infectious Diseases Journal, that looked at what were small numbers of people, but I wanted to point them out because it sort of sheds light on one of the things we were really worried about. So one of the things we were really worried about is that this rebounding, could this be happening because we're getting drug resistance? So this would kind of be a little bit of a, this wouldn't be a good situation, having drug resistance at this stage of the pandemic when we're still active and evolving. We don't want to be, through our treatments, creating pressure that will cause it to mutate more and be resistant to the Paxlovid. So that was kind of the big worry with it. So there's a couple of reassuring studies. One of them came out of UC San Diego. And what they did was they actually just looked at one patient, but they isolated SARS-CoV-2 from this patient who got the rebound and tested whether there was any drug resistance in that SARS-CoV-2. And what they found is that the virus was still sensitive to the drug and didn't show any mutations that would reduce the effectiveness of the drug. So big relief. The next thing they did was sample the patient's plasma to see how their antibodies were looking against SARS-CoV-2. And what they found out is that the drug did not affect the patient's antibodies. Those antibodies were still effective at blocking the virus from getting into cells and infecting them. And so this also is a big relief because it is not showing that the drug in any way is affecting the person's antibody mediated immunity. So that basically that wasn't the cause of the patient getting symptoms again either. So what they kind of concluded is that probably the rebound has to do with not enough of the medication, so maybe not enough days to stop all of the viral replication. So it suppressed it, but the virus was still able to keep on replicating after the 5 days. And they also suggested, and this is just sort of a hypothesis at this point, maybe some people metabolize the drug more quickly than others. So maybe that is why some people get the rebound and others don't. And so that maybe the drug does need to be a little bit longer course than the 5 days. That we still don't know if this is the case yet, but again, I think this is a huge relief in terms of not, not being because of drug resistance. And basically, the other thing is that this individual, as we're seeing pretty much across the board, they're not getting sick enough to be severe or to be, to go to the hospital for the most part. And I'm going to talk a little bit more about that in a second. But there was a second study that looked at 7 patients that had this rebound of recurring symptoms and also a positive test again. This one looked at whether they had virus that they could culture. And a few of them did, 3 out of the 7 did for over 2 weeks afterwards. But in none of the cases were they able to find any mutations that would give this virus resistance to the Paxlovid. So once again, that is all very reassuring. So I think that the most concerning potential reason for rebound seems to have, at this point, been ruled out. Of course, we'll just keep on waiting for more and more studies, but at this point, we have no reason to think that that is the reason. So now I want to talk about a really big study, and this was a preprint that was posted on June 22nd, and it is a retrospective look. So they look back at a cohort from electronic health records from multiple centers and nationwide database in the United States, and this looked at 92 million patients. So this is a nice big sample or study population. And this then looked at 13,644 people, 18 and up, who contracted COVID from January 1st to June 8, 2022. So this is all pretty much during the Omicron period. So that is really useful information. So real world data during Omicron of over 13,600 people who had COVID, and out of those, 11,270 got the Paxlovid, 2,374 got the molnupiravir, and this was within 5 days of their COVID infection. So what they were really looking at was COVID infection and symptoms and hospitalization. So did these things come back? And what they found out was that there was rebound, and in some people this happened a little further out than what I think we've mostly been hearing. So they looked at 7 days and 30 days, and they found out that there was rebound infections of about 4% at 7 days and about 5% at 30 days, and that there was a rebound of symptoms, again, sort of in this 5-6% area. COVID hospitalizations, this was 0.4 and 0.8%. So less than 1% of individuals actually got sick enough to go to the hospital. And I did not see any of them any deaths reported here. So Paxlovid is remarkably effective at reducing progression to severe illness, at reducing hospitalization, reducing ICU, reducing death. So that is great news. And that is irrespective of this rebound phenomenon. So it does not appear that rebounding with the symptoms or with a positive test means that these folks are going to get sick enough to go to the hospital. So saying that to say the benefit of Paxlovid remains. The other thing I thought was interesting about this study is that it showed this rebound happening actually a little more with the molnupiravir. Wasn't statistically significant though, but it was a little higher with the molnupiravir than the Paxlovid. And those two drugs work really differently actually. And so what I think we are seeing here is that this rebound phenomenon is not specific to Paxlovid. There's even been some folks who are theorizing that there's a sort of this ebb and flow of symptoms, even in people who don't get treated. So that some people do start to feel better after 5 to 7 days, and then the symptoms can come back. And we've seen that sort of as we're investigating long COVID and how that kind of the natural history of this viral infection happens in some people. So rebound is not unique to Paxlovid. It also happens with molnupiravir. We're not sure if anything like this really happens for untreated folks or other treatments. The other treatments that I mentioned, the IV ones, will need more study to understand and learn this. And so I think what this is saying is that we really need to keep our eye on this. And why do I say that? It's not because I'm worried about the patient who took the Paxlovid. I feel very confident that if you are a person who is eligible for Paxlovid, you should take the Paxlovid. This rebound does not make me shy away from that, not in the least bit. There's not any evidence here that suggests that somehow that this rebound is connected in any way to poor outcomes. But what I am concerned about is the fact that people are becoming contagious again, and they may think that they're not. They may think that they're done. So we really need to learn more about this quickly so that we can give the right advice to people who took Paxlovid. So we need to understand better why this rebound is happening. And we're going to need to test different, maybe different doses, different duration of the regimen, so that we can prevent rebound. Because I don't even like that 0.4% or that 0.8% going to the hospital with rebound. It's still extremely low. So again, it's definitely, we need to be giving the Paxlovid for those folks, but we don't want to see rebound if we don't have to see rebound. So if the duration needs to be longer, we need to figure that out in short order. So what do we need to do in the meantime? So I do think that the 5 days is what we've got. So until there's evidence to say that we need to, and guidance really, we need evidence and we need guidance to say that we need a longer duration of treatment and that will actually give us better outcomes. We do not have that yet. So right now it is 5 days and clearly it is working. It is working very well. For high-risk individuals. So really, if you're unvaccinated, if you're over 65, if you have multiple comorbidities, those are the people we want. I mean, if it was up to me, everyone that was eligible, just have it on hand, ready to go in case they catch it. We're not quite there yet, but hopefully we'll get there. Now, the other thing that we can say is that Paxlovid rebound is definitely a thing. And when it happens, first of all, you need to check for it to know if it happens. So what I would suggest is that we sort of keep testing even after, even after those 10 days. As I explained with that previous study, some people are getting the rebound even after sort of that 2-week period that we normally think of as the isolation period. So what do we need to do? We need to test. So even after the Paxlovid, I think if you get symptoms again, if symptoms sort of come back after the 5 days of treatment, then yes, definitely, please do test. But it's sounding like, and what I think the data is suggesting that we need to do in order to kind of err on the side of caution right now is go ahead and keep testing in that next couple of weeks after you complete treatment, just to be sure that you don't become contagious again, because we really don't want to put others at risk. And if you do test positive again, even after treatment, then you can assume that you are contagious. And this is the antigen test. Remember, the PCR is going to be positive for some time. So we're not talking about PCR. We're talking about doing a home test or an antigen test in order to see if you are getting this rebound phenomenon. So symptoms, definitely test, but even without symptoms, go ahead and keep testing. And I think if we're going to be super conservative and careful, you may want to kind of spot check yourself for the next several weeks. But what do you do if you turn positive again? Well, unfortunately, and this is the part where it is a little inconvenient, annoying, is that you would need to restart the isolation period. So sorry about that. But if you test positive again, then you're sort of back to day 0. So remember, we're going to start counting day 0 if the symptoms come back or if the test is positive again, and then restart that isolation period. So annoying, yes, but definitely well worth that 80+% reduction in hospitalization and death. No question about it. So at this point, what are the best things that we can do, knowing that we've got this more contagious strain out here, this BA.5? And so we know that vaccine and booster are sort of our best bet. That is what is really remarkably reducing not only the risk of sort of a severe outcome, but likely the risk of catching it and getting long COVID, all the data there is very, very difficult to sort of give percentages anymore. We have too many variables unlike before, back in the old days when we were able to say what percentage reduction were we getting. It's kind of all over the place, but we absolutely know that it is reducing risk. And so vaccine and booster, and as I've reviewed here, the first booster is recommended for everyone 5 and up at least 5 months after the primary series. And then the second booster is at this time being recommended for everyone 50 and up, or those 12 and up with immunocompromised at least 4 months after the first booster. The question I'm getting a lot of right now is, what about the variant-specific booster? Should I wait? Because we've heard the news that it looks like as early as this fall, we may have a more variant-specific booster available. So should we just wait for that one? So a couple of things about that. One is that, first of all, there's actually no guarantee we're going to have it by then or that we're going to have enough. So there was a White House briefing, the link is in the post, in which Dr. Jha said, we will not have enough vaccines. And he's talking here about the bivalent vaccine, meaning it's got the old school COVID, and it's got the Omicron, not the BA.5 though, so got to keep that in mind. But even at that, we will not have enough vaccines for every American who wants one this fall and winter. That is a quote from the White House. So we should have, he says, we should have enough for potentially high risk individuals. So that sounds like a lot of shoulds and maybes and won't probably have enough. So I would not be banking on the fact that we will all have it available to us. Now, even if we did though, is it worth waiting? And so I think, first of all, if you have not gotten your third dose and you're due for it, so if it's been more than 5 months since the primary series and you have not gotten your third dose, so your first booster, there's absolutely no question in my mind that that's the best thing that you can do to protect yourself right now. BA.5 is very, very contagious. And even though this vaccine is not specifically tuned to the BA.5, there's no question that the boost of antibodies that we are getting from the booster is giving significant protection. What percent? I don't know. We really don't. We can't really say right now. And that's also because people are different time periods out from their vaccine. They may have had COVID infection. So we've got this huge hodgepodge of situations that makes it very, very difficult to give those percentages that I know we all want to hear. But just know that it is significant. It is better than not having it. And right now, I would strongly suggest if you haven't gotten that first booster, that is recommended for everybody 5 and up, at least 5 months after the primary series. Get your first booster. The second booster. So you're hearing people all over the map with this. You've got people saying everyone should be able to get a second booster, no matter how old you are. It shouldn't just be for immunocompromised people, and it shouldn't just be for 50 and up people. Then you've got people saying, well, I don't know, maybe we should just wait for the next round, the variant tuned one. And so I think, the guidance is pretty clear that if it has been more than 4 months since your first booster and you're 50 and up, that this is recommended because it is reducing hospitalization. Now, how long is it going to be helpful? Is it a month? Is it 3 months? 5 months? That part is a little more elusive and we don't really know. And is it worth waiting to see if we're going to have something more variant tuned? Well, first of all, I know that we don't want to feel like we're just constantly boosting, every 4 or 5 months. So I get the question completely. But what I worry about is that if you are one of those high risk people that might be eligible in the fall that will get this finely tuned, variant tuned, or better tuned vaccine, then you're someone who I'm worried about you waiting too long and going too long without a booster. So this is a difficult balancing act. If you are immunocompromised, I really, really hope that you are in these conversations with your doctor and making these decisions. And that frankly, if you're truly immunocompromised, that you have considered or discussed with your physician Evusheld. So that is the monoclonal antibody that is pre-exposure prophylaxis. So this is the one that's going to actually give you antibodies, because remember, we do worry that if you're immunocompromised, we don't really know how good your response to the vaccine will be. And that is where the Evusheld comes in and gives 6 months of protection. It appears to be holding up well against all these different variants. So that is something that you should really strongly consider. So vaccine, up to date with boosters, not letting it wait too long on a hope and a prayer that we may have something in the fall, because frankly, it's not the BA.5 vaccine. And that is the one, as I just showed, that we are contending with. So will it still help? Yes, it will, because basically mounting sort of a diverse response. Our immune system mounts a very diverse response, and having this, whether it is the current one we're dealing with or whether it is a future one, I don't think we're going to keep be able to chase variants like this forever, because by the time we come out with the new formulation, a new variant is on the move, especially at the high rates of transmission that we have allowed for ourselves, because we have been unmasking, we've been doing more flying and more gathering and not taking precautions. And this is, to me, a failure in many, many ways. And I think that we should all really think about, how we individually and collectively within our circles could be making better decisions so that we're not contributing to this problem. And the problem is that with such high rates of transmission that we've just decided to accept, apparently, we are unfortunately setting ourselves up for a situation where we have the more transmission, the more variants evolve, and then we stay behind on developing everything. So it may be that the next variant evades completely. We're lucky we haven't gotten to that point yet. So I do want to stress that. So far, we have not ended up with a variant that just completely evades all of our prior immunity 100%. That will not be a good situation. And I hope we won't have to contend with that, or that we end up with a variant that evades our tests or that evades our treatment. So it could certainly get worse. So we are still very much in an evolving active pandemic, and we need to understand that the situation we're in is not ideal, and that it won't be like this forever. But right now, with these high levels of transmission, the best protection you can do for yourself is Evusheld if you're immunocompromised, vaccine and up to date with your booster, but protect yourself from getting it, right? Avoid getting it. And so we're going to be masking. We're going to be gathering outdoors if we can. We're going to be upping our mask game. So we are going to be using a high filtration mask, an N95 or a KN95. And we are going to be trying to eat and drink outdoors. And if we are going to be indoors with others, what is the ventilation like? We really need to be paying better attention to improving our indoor ventilation. That can mean opening windows and doors, and improving our HVAC systems and so on. And for those who own businesses, who are the boss, who own venues, who basically are responsible for the health and well-being of others, please think about investing in a better system, HVAC, HEPA filtrations, and so on. And really, we know that despite all of this that is going on and all the evolution that we know is going on, that the vaccines and the boosters are preventing the most severe and tragic outcomes in the vast majority of cases. And for those who are still vulnerable because of their older age or multiple conditions that they may have, treatment. So that next layer, that treatment. And we're not going to wait until we see how we feel. If you are in one of those groups, then don't wait to see how you feel. Now, you could argue, and some experts that I respect are arguing, that if you're kind of in that gray area, maybe you're 40 and you have asthma, and you're vaccinated, maybe you're the person that's going to wait until day 3. And if you're already feeling better, then you're not going to take the Paxlovid. But if you're feeling horrible, then maybe you will. I could maybe get behind that argument in that case. But once again, if you are someone that we are concerned about progressing to severe illness, I want you to have that Paxlovid on hand so that you can start taking it as soon as possible, because the sooner we reduce that virus from replicating, the better chances that we have of it getting out of control and progressing to a point where you need hospitalization or even worse, ICU and so on. And so on that note is making a treatment plan now. Determine if you're eligible, and if you are, how are you going to get it if you test positive? If you don't have a primary care provider, please get one. Make sure you know how to reach them now before you need them. Please maintain a balanced and nutritious diet, get some exercise, manage your stress, consider a multivitamin supplement with vitamin D, and get a good night's sleep. This concludes today's People's Health Briefing, and we'll look forward to seeing you again next Tuesday at 10 a.m. See you then. And in the meantime, please stay safe.